Welcome everyone to today's webinar about how Trinity drove $23 million in labor cost savings. On behalf of Becker's Healthcare, thank you for joining us today. Before we begin, I'll walk us through a few quick housekeeping instructions. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you have trouble with the video or audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. I am pleased to introduce today's speakers, Lisbeth Lotruba, Chief Clinical Innovation Officer at AvaSure, and Gay Landstrom, Senior Vice President and Chief Nursing Officer for Trinity Health. So with that, Lisbeth, feel free to take it away.
Hello, I'm Lisbeth Lotruba. I'm the Chief Clinical Innovation Officer at AvaSure. And before joining AvaSure 8 years ago, I really grew up professionally in Trinity Health at Mercy Health St. Mary's, where I started as a critical care nurse and in various roles over 13 years. And that is when I first met Gay Landstrom and have admired you ever since. And I'm just pleased to count you as a friend and colleague now, Gay.
It's great to be with you, Lisbeth, and a delight to be able to tell our story together.
So, Gay, if you want to introduce yourself to a little bit of...
Sure. My name is Gay Landstrom, and I serve as the System Chief Nursing Officer and Senior Vice President for Trinity Health. We're a large Catholic healthcare organization with ministries spread across 25 states.
And responsible for the nursing practice of 30,000 nurses in various settings.
That's
so
correct.
A nurse's nurse. So the story that we're going to tell today has several layers to it. And obviously, we're going to talk about a telehealth solution that has measurable patient safety and staffing efficiency outcomes. But we're also going to talk about how that was scaled across a whole system. And then on top of that, how Trinity Health dramatically shortens the implementation timeline at the very beginning of the pandemic successfully. So that was, it was exciting and really excited to share the story. So just at the beginning, I'm going to start by providing some general context about what AvaSure does before handing it over to Gay to talk about the more specific Trinity story. So at AvaSure, we are the inventors of the TeleSitter solution, and our mission is we help people keep people safe, and have been doing this for hundreds of implementations across the United States. And it's not just a technology that you implement without a lot of clinical support. So at least one in 10 of our employees is an RN. And because we really want to be there to make sure that we are supporting a clinical implementation based on our experience, because it's a new way to deliver care. So the challenge, and I promise we're going to get to an optimistic place, but the challenge starts with a lot of patient safety issues that occur in the hospital setting. One of that is most measured and is most expensive by far are falls. And the cost of falls is not only the human cost and the fear that it creates and even higher mortality rates for older adults, but it's non-reimbursed calls, it's extended length of stay, it's litigation. So falls being a big burden, and also behavioral health patients kind of ending up in the hospital setting as the last safety net because of lack of the right environment sometimes. And that can lead to, and that is growing with the opioid epidemic and mental health issues before and during the pandemic, where patients are at risk in the hospital setting. Sometimes patients are using illicit drugs in the right in the hospital or in the emergency department. There are issues with violence against caregivers. There's self-harm. And I think we all have heard the OSHA statistic that healthcare workers are 4 times more likely to suffer violence than those who work in other settings. And really without another option in the past, healthcare and nurses have just had no other option but to utilize one-to-one sitters on up to 5 to 10% of the patient population that is most at risk. The problems with that, though, is that that's an entry level, like a nursing assistant level position, and the turnover on that position is extremely high. It was 28% before the pandemic. And literature has shown study after study that using sitters actually doesn't improve safety. It's kind of counterintuitive. A lot of studies show the more sitters hospitals use, the more falls they have. And it's really about a very inefficient use of staff. And lastly, this is not something to be ignored, but this one-to-one sitters are often put in one of the most dangerous positions, and 80% of sitters have reported experiencing violent events. AvaSure was the inventor and market leader in the TeleSitter solution that is a telehealth solution that can help address this. So you can see in the foreground their mobile device with a camera. It has really crisp audio, night vision, 360-degree pan tilt zoom that allows a remote trained staff member to keep multiple patients safe. Reducing one-to-one sitter costs, preventing falls, addressing some of those behavioral health challenges, and also workplace violence prevention. Just last week, there was a customer in a hospital in Texas telling us that their monitoring staff member was monitoring a patient who was very agitated, and witnessed when the nurse had turned her back, witnessed them taking the metal knife off the tray and sticking it down in his pants. And so the monitor staff member was able to say, "Oh, Mr. Jones, can you take that knife out of your pants and put it back on the tray table?" And there was an escalation, and security came, and everybody was kept safe in that situation. And so how that works on the other end is those trained monitoring staff members are like lifeguards, watching multiple patients, interacting verbally with them, or interacting with the bedside staff, or in an emergency able to trigger an alarm. And Gay, this kind of reminds me of what my mom talked about when she was a nurse in Duluth, Minnesota. She was a nurse on a ward. And so she would 24/7 have line of sight to her patients. But I've never worked in a setting like that anymore. And I don't think that's great for privacy and patient dignity, but there is this importance of certain percentage of patients need that higher level of visibility. And it's a proven intervention as well. So it has really become a standard of care in patient safety. With many articles and presentations over the past many years, demonstrating a decrease in falls, over 50% decrease in falls, and a decrease in one-to-one sitter costs. There have been over 50,000 patients in the AvaSure database that have been monitored who are at low to moderate risk of suicide, and they've been kept safe. University of Wisconsin published about decreasing their cost of managing adolescent eating disorder patients, not having to use one-to-one sitters for all of them, instead of using the TeleSitter. There was a study published in the Journal of Nursing Care Quality across 73 hospitals talking about workplace violence events that were prevented and documented. And also during COVID, there was a big need for that level of interaction and even worse, ability to have line of sight when was needed. So we provided over 420 free software licenses during the different surges to make sure that everybody who needed to have access to that line of sight for their patients could. And put up another monitor at isolation units so that nurses right there could also interact with their patients. And I just want to, so I hope I've just painted a picture of AvaSure, why AvaSure is a market leader and the inventor of telesitting, but I'm just really eager, Gabe, for you to tell the story from Trinity Health over the last few years of centralizing.
Great. Thank you very much, Lisbeth. And I will just share with you, it has been a delight to work with you and all of the staff at AvaSure to help us make this happen. And when we needed to speed up, help us do that very quickly. So next slide, please. Great. There were a number of reasons a number of objectives that we needed to accomplish with this project of using the AvaSure technology. We actually had used the AvaSure technology in a couple of our states for a number of years. It might approach a decade. And so we had some really good experience in one state that was then replicated in another state, but we had never really scaled that solution across the entire enterprise. So we had a higher level of safety in some of our facilities, but not in others. And we wanted to improve the safety of our colleagues. We wanted our at-risk patients to be safe. We wanted to steward our resources. All of you in acute care know that revenue doesn't usually go up every year. We have challenges every year. And so we need to use our resources wisely and to accomplish the best outcomes with patients. We wanted to use technology to help us keep patients safer. We wanted to advance nursing practice, and because we had begun to implement this solution across our system when the pandemic hit, there was a greater urgency. Once we experienced March of 2020, we needed to really speed this up and accomplish implementing this across our entire system by really by the end of February, 1st of March in 2021.
Yeah, we had a plan. And then we crumpled that up into that. I mean, I think the original plan was 3 years.
Yes, we were going to steadily go from state to state, facility to facility, implementing the AvaSure technology. And when the pandemic hit, there were a number of projects and initiatives that we needed to just pause on, as others did across the country. We needed to take care of these COVID patients while we were trying to figure out the best way to do that. But this was one project that our CEO said, Gay, we needed this. We needed this done a long time ago. How fast can we make this happen? And the first call was to our colleagues at AvaSure, and the question was, how fast can we do this? We'll rally the resources we need. Do you have enough cameras? How fast can we go? And then working together, we were able to get this completely rolled out across our entire system by the 1st of March in 21, which was amazing. So this is the way that we are set up. We created 2 hubs. Rather than individual hospitals having a little hub in the basement or somewhere monitoring these cameras and talking with patients to keep them safe, we really believe that we could do this more efficiently and be able to provide more consistent service by creating sort of two super hubs that would monitor patients across the country. And AvaSure, the technology had advanced to the point that we really could have a couple of hundred cameras that were sending signals to these hubs, and the team in the hub could be working with patients anywhere across Trinity Health. So we selected two locations where we believed we'd have a good supply of workforce, and we had data centers close by, and then we began connecting our facilities to these two hubs. And you can see on these two maps that we were able to make connections clear across the country. And one of the things that, of course, needed to be tested with any technology is how well did it work? With this technology, we needed to make sure that there weren't latency issues, that there wasn't a delay in the signal being able to get to the hub, or if one of the technicians in the hub needed to speak with a patient, that there was no delay. And we did lots of testing, and it worked really well. We really could send that signal all the way across the country without delays.
Yeah, and the average length of stay for a patient that needs this level of monitoring is 61 hours. So 61 hours, zero latency on a mobile wireless device from California to Connecticut.
Yeah, it was kind of amazing. I was a skeptic at first, and it had to be proven to me that we really could do that, but it was exciting to realize it really could work. In order to make this work well and scale the solution across our system, there were some supports and processes that we needed to put in place. We created a standardized playbook that each one of our facilities had in hand, so they knew how would this work. If the technician in the hub needed to talk with the nurse at the bedside, how would that work? When were the circumstances that the technician might want to hit that urgent alarm, so that the nurses on the unit knew that there was an urgent need for assistance in a room? How would that work? How would we, when we identified that a patient was a great candidate for monitoring through the AvaSure technology, how would we make sure that everyone knew we were bringing that patient on? How would we get them into the system? All of those kinds of processes we needed to standardize so everyone knew how it was going to work. And then the individual facilities, our ministries, needed to provide the day-to-day management and take care of those cameras. We couldn't do that from the hub, and they needed to really assign with the cameras that they had who were they going to, which patients would they be used for, and so forth. We had great connection and ongoing communication between the hub leader and then whoever was the leader out in the facility. And when we had some issues or miscommunication and needed to really work that out and smooth out our processes, improve the playbook, that we had ways of connecting regularly and sharing those issues and ideas and opportunities for improvement. We did set up that this is really a precious resource, being able to use the AvaSure monitoring. And just like the use of our sitters, we established that every 4 hours, we really needed to look at whether this level of resource was needed, whether it was, a one-to-one sitter or the use of the AvaSure cameras. And if a patient no longer needed it, then we would remove them from that monitoring and be able to use that with another patient. So there were a number of things that we needed to make sure our entire system, all of our nursing teams in all of our facilities were going to be working with this technology in these hubs in a consistent way.
Yeah, that steering committee is definitely a best practice. So just make sure you're having that communication between the hub and the spoke leadership.
This gives you just a little picture of how the whole system works. We have a patient who is out in our hospital, might be in any of our states, and the camera, when a patient's determined that they really need this kind of monitoring, the camera is brought into their room and positioned in a location that can really give the best visibility of the patient. If there is, if one of the risk is that a patient might be confused, might try to tug out a tube, or might try to get out of the bed when they're really at a very high risk for falls, for instance. Wanting to position that camera in a way that we clearly could see the patient and recognize the behavior and intervene really quickly. As I mentioned, we have we use two data centers in different locations across the country. And then this is just a photo on the upper right of one of our hubs, and a little bit different than the photo that Lisbeth showed you earlier. We did decide to really try and create as quiet an environment, because these were pretty big hubs with numerous people, each of whom are observing 12 patients and talking, could be talking with any of those patients at any given time. We wanted to keep as quiet an environment as possible for those conversations, while still maintaining the whole team atmosphere and people not feeling like they're alone. And in fact, the way we set up the staffing is that we have our virtual monitoring attendants who are watching their 12 patients. They also have a supervisor who is checking on them and making sure that are they becoming sleepy? Do they need to be relieved so that they can take a little break? Are they encountering some things that really are raising some questions, like the case of the patient who who had procured that metal knife? For instance, when they need consultation, we make sure that that supervisor is available to really help them problem solve or be a second set of eyes. What are we really seeing, and what is the best action in order to keep the patient safe and communicate appropriately with the nurse at the bedside? This is just another view. We have virtual monitoring attendants who are working with patients all across the country. So we have multiple clocks with multiple time zones, just to help keep people oriented to if they happen to be in the Eastern time zone in their hub, but are working with the patient on Pacific time, that they can keep that kind of orientation clear. And then one of the questions that I often get from people is just, what are the situations where the monitoring with AvaSure is, is really advantageous? And this just gives you a little snapshot from last year. Actually, it's a segment from last year. And this is what we were seeing as the diagnoses of the patients that were being monitored through AvaSure. And you can see there's a fair amount of dementia and delirium, substance withdrawal, or even some psychiatric disorders. These are patients who can be redirected. They might not remember that the nurse said, "We really do not want you to get up alone. You're fragile, you're weak, you're at risk for falling. We always want to assist you." And the patient may forget and then try to get up and then take a fall, which could injure them greatly. Or they might wake up confused in the hospital. We know that hospitals with noises and smells, and then the patients on medications that can lead to confusion, they might not know what is that tube that is attached to me and might be tugging at that tube, not with the intent of hurting themselves in any way, but just confusion. And they need that attendant to see that behavior immediately, and then and know that patient, know their name, you know, have spoken with them earlier, and it's the opportunity for that safety attendant to be able to redirect the patient. And if the patient can't be redirected, maybe their delirium is so deep that they really need the intervention of one of the caregivers at the bedside, then that's when the AvaSure monitoring attendant can engage the staff at the bedside to work with the patient, again, to keep them safe, to prevent harm, and to be those eyes continually on a patient who's particularly at high risk. One of our goals was that we wanted to prevent all kinds of harm. And, you know, I've mentioned a couple: the potential for falls, the potential to pull tubes out, the potential to do, you know, anything that might harm the patient or another. One of the areas of focus for us was we really wanted to reduce the incident of falls with injury. And this was one of our strategies. And one of the reasons why we successfully argued that we needed to invest in this system across our entire organization. And so this just shows a little snapshot of time when we were steadily implementing the cameras and hooking them to the hubs. During that time that we were climbing in the number of sites that were on AvaSure cameras, our falls were coming down and have been quite stable. We'd like to get rid of those last, you know, 35 in a quarter, but they definitely came down and have been quite stable. And
in an environment when adverse events are rising, because yes, if you look at this timeline, this is the time that's there's been tremendous shortage of staff is spread thin. You've got travelers, and then a lot of patients who are behind shut doors that you need, you know, PPE to run in. So the idea, even the idea that it didn't climb is a win during these last couple of years.
Yeah, absolutely. And remember, during the pandemic, there were good chunks of time where a family member or significant other could not be with the patient.
Yes.
And, you know, we always try and enlist family to help keep the patient safe, help remind the patient not to get out of bed alone, things like that. We didn't have those additional eyes and members of the team. And yes, doors were shut if a patient was infected with COVID. And yes, it took longer to get in that room because you had to don PPE. There were a lot of reasons why people could have fallen at much greater numbers. But it was during that time that we implemented this technology and our falls actually went down. I think had we done nothing, Lisbeth, I think it would have been an upward climb in this graph.
Yes, yeah.
So one of the questions that is always asked is, you know, as I mentioned earlier, one of the objectives we wanted to accomplish was that we were lowering the cost of sitters during the time period in a couple of years before we began implementing our hubs and this system-wide solution. Sitters and the use of sitters, the reasons to have sitters were just climbing everywhere, every part of the country. As I talked with my colleagues in other systems and other hospitals, they were telling me the same story, that the demand for sitters was climbing. At the same time, it was really hard to even find enough sitters. So if you didn't have enough sitters, people whose entire job it was to sit and keep people safe, then you would start to draw on maybe your nursing assistants, and then they weren't available to be part of the team with the rest of patient care because they were watching one patient. And we even had situations where we didn't have enough sitters and there weren't enough available nursing assistants, and we would end up having a registered nurse serving as a sitter, which was greatly underutilizing their skills. And we even had an extreme circumstance where we not only had to use an RN for a sitter, but it really resulted in the need to use a contract labor RN to backfill. And so just crazy costs tied with the need for sitters. So sitters were on the rise. There was the cost of those sitters. There weren't enough sitters. And so we were really at a situation where our costs of sitters was approaching $28 million across our enterprise. And we are a big enterprise, but that is an awful lot of money. And we were able to bring that down. And it's just logical. A one-to-one sitter is a very costly resource. But when you have one virtual monitoring attendant who can work with and watch 12 patients, the ratio just makes sense. Even with the added investment of the technology itself, we brought down our costs tremendously, and certainly needed to do that. Just another picture of the reduction in actual use of FTEs. And to be perfectly honest, it's hard sometimes to capture all of the use of all the FTEs that were used for sitters, because again, there were the people whose job it was to be sitters. Those were easier to capture. But then making sure that everyone actually coded the hours that they spent as a sitter when they're a nursing assistant or an RN, we didn't always capture those. So we know that. But even with the data that we captured, we reduced the use of those patient safety attendants, our sitters, and we reduced that by 85 FTEs. And again, we know that it's more than that, but we were able to capture data to show that we reduced by 85 FTEs. We mentioned a little bit about this. The reasons for falls and the risk for people to fall really climbed during the pandemic. Now we may not have huge numbers of COVID patients in our hospitals, but now most facilities across the country are struggling with workforce shortages. So yet another risk, if you will, of patients falling. And we are so grateful that in the situation that we find ourselves right now, that we have the AvaSure technology to help us keep patients safe. We also know that that the behavioral health challenges that rose during the pandemic, they seem to continue to rise, and the literature and experts that I talk with are just really concerned about the increase in behavioral health needs, and in many cases, the lack of resources to really address them. AvaSure has helped us with patients who have low or moderate risk for suicide. It is not appropriate technology for high risk. Right. There, we still have to continue using the one-to-one sitter by regulation, but for low and moderate risk, particularly the moderate risk, it is a really good solution, and has been critical for us to be able to keep our patients safe. And again, the workforce shortages across the country, I don't think we have peaked with our shortages and our challenges. And this is yet another, this is another part of the team. I should mention that one of the things that we did as we set up these hubs was we wanted to make sure that that the nursing staff that were in the hospital caring for the patient really viewed that that monitoring attendant as another member of the team. They are Trinity Health employees. They just happen to be in a hub across the country,
Yeah.
but they are concerned about your patient and keeping them safe and working with you at the bedside to keep that patient safe. And we continue to really press that cultural element that this is another member of the team working with you to keep this patient safe.
Gay, and to illustrate that point, do you mind sharing that story that you had shared with me earlier about that COVID patient?
Sure.
And
sure.
the TeleSitter who just really, I mean, we've been talking about big numbers and percentages and but just so it's about individuals too.
Yeah, it really is. Well, one of the stories, we have many stories where I've just been so proud of our virtual monitoring attendants. They really, many of them have a high school education, and we train them on how to safely interact with patients and form a relationship with patients, use the technology, and so forth. There are things that we have not taught them because we didn't expect that they would ever need to deal with this kind of situation. So what occurred, if you'll recall, some of the big surges that we had early in the pandemic, we had a lot of patients hospitalized, and we experienced patients who were dying of their COVID disease at a higher rate than what anyone dreamed of dealing with. I've had registered nurses tell me, you know, in my entire career, I've only dealt with X number of deaths, and I would experience that same number of deaths in maybe 2 or 3 weeks. It was just so much to deal with. And sometimes a nurse would have 2 patients actively dying at the same time. And we who are nurses know that to us, it's a rule. We never want a patient to die alone. Mm-hmm. This was also during the time where we weren't allowing family to be with the patient because we were trying to protect the family. Those things loosened up a little bit as we went along, and we were able to have patient or have significant others and family with a patient who was dying. But this was in the really early days. Yeah. And a registered nurse had 2 patients actively dying at the same time. And the other nurses on the floor were also dealing with patients who were very ill and in their last hours. And one of our virtual monitoring attendants realized what was occurring with this patient that she was watching, because she was also watching the nurse's other patient. And the registered nurse needed to be with one patient who was actively dying, and the virtual monitoring attendant, knowing that a patient should not die alone. She had heard that from her nurse. And that virtual monitoring attendant saw that that need was there. We had not trained her to do this, but she stayed with that patient and sang to the patient as they passed. And which I really believe had to be important for that patient. I know it was really important to the family, who was agonizing over not being able to be with their loved one, but to hear that they weren't alone. They were with a virtual monitoring attendant who sang to them as they took their last breath. So that's amazing. It's not something that we planned for or trained our monitoring attendants to do, but they saw the need, and they are people with compassionate hearts, and they just stepped into that need, and it's a really beautiful story.
And it just illustrates how I think that's what we strive for, is to find that sweet spot where technology can support and enhance what caregivers are doing, but not replace. And that is, you can't do that with sensor-based line that you draw around the bed. You know, it really, that human factor is so important. And it sounds like you had really good hiring criteria. And so I'm sure you maybe didn't train to that exactly, but I'm sure you had amazing orientation. And I think it might be that oversight that you're able to provide when you have such a large hub, that you can kind of afford the luxury of that supervisor who can be on standby for support as well. So it just makes so much sense to have that centralized rollout. So thank you so much. You know, you complimented us on helping with do a really shortened timeline from what we usually do. But here at AvaSure, when you said, can you do it? Can you help us? We were just thrilled to feel like, oh, this is something that we can do, because, you know, we all felt so helpless. And so it was just an honor to be able to roll up our sleeves alongside you and help get this out into needed patients. So thank you so much for your time today. And I know that I think there might be a few frequently asked questions that we wanted to address before we close out.
Okay, I'd be happy to answer any questions that have arisen.
Perfect. Thank you, Gay and Elizabeth, for a great presentation. We also wanted to give you the opportunity to share your insights on some frequently asked questions we see. The first question is, what did you do to get started, and why did you implement? Sure.
Well, first of all, we had some experience with AvaSure, and I recognized that we had this great intervention in a couple of our states, but not in all of them. And but we really had a need. So our experience really led us to be confident about taking this solution and spreading it, looking at a creative way to bring it to all of the hospitals within our system. And we, as I think I mentioned earlier, there was a growing demand for sitters. There was a growing cost of sitters, and there weren't enough sitters to meet this need and keep patients safe. So we needed to keep people safe. We needed to use our resources efficiently, and we had this great experience with AvaSure. So really bringing forward a case to our system leadership that here's the situation, you know, with these rising costs, this rising need, patients need to be safe, and frankly, sitters don't necessarily reduce falls. We needed a different solution that had been proven in a couple of our states already.
Wonderful. Thanks so much for sharing that. The second question that we have is, what is one takeaway we could use to make sure we are set up for success?
Well, I think it's really important to address that nurses and nursing staff have probably spent years working with sitters, and even when they see research that shows, you know, having all those sitters doesn't necessarily reduce your falls. There are all kinds of reasons for that, but it's not really helping us accomplish reducing falls the way we need to. And then converting from, instead of, if my patient needs some added safety, they're at risk for pulling something out or getting out of bed when they shouldn't, or hurting themselves in some way, instead of going to that, I need a sitter, trusting that their colleague in the hub can work through this technology and help keep patients safe. Oftentimes staff are, they're a little bit in disbelief. They know how the sitter thing works. They've worked with it for years, but working with a technology and trusting that somebody who's not necessarily from their facility, they're in another state, but a Trinity Health colleague, getting over that hurdle of really seeing how this works and that they can rely on AvaSure and not keep going back to what they know best, the sitter, it takes time to do that, and really attending to that culture shift and that belief and attitude within the staff member. Sometimes it's case by case. It's really, okay, you may have a sitter there, but let's put the AvaSure camera on so you can really see how this attendant works and is really staying on top of watching your patient. And it may take an experience for belief to develop and really help that nurse change what they're going to do the next time. It's important to take that time and really help people believe that it is a solution that is going to achieve better outcomes than the sitter.
And storytelling. And I think that is something that you did very well also, is when there was a great catch or just a heartwarming story like the one we just talked about, to share that because that connects with people sometimes more than stats do. And another best practice that I noticed we talked about briefly, but very important, is that reevaluation to make sure you did every 4 hours, or sometimes it's 8 or once a shift, to make sure that AvaSure provides data to help too. This patient hasn't needed any interventions for 4 hours, and are they coming to the point where their behaviors are improving, maybe their substance withdrawals clearing, and so that you can reallocate that precious resource to another patient who needs it more. So I loved that you mentioned that continual reassessment.
Wonderful. Thank you both for expanding on that. And one more question, if you had to do this again, what would you do differently?
Oh, that's a great question, because, certainly experience is such a great teacher. As the pandemic went on, the workforce shortages, we had all kinds of new workforce shortages that started. Everybody was seeking those high school grads. I mean, McDonald's became competition, and we just had lots of competition for these safety attendants. And while we have been developing career paths for them and reasons for them to stay with us and not be lured away, I wish we had started with planning those career paths and even advancement models, things that would really urge people to make it sticky, and they would want to stay with Trinity Health. We did that sort of on the back end, but I wish we had thought about it sooner and really planned for that workforce to really want to stay with us and see a career path ahead of them.
That's a really great point, and it is a great career stepping stone. It's a wonderful place to start. Whenever I'm meeting new monitoring staff members, I say, "Are you thinking about nursing school?"
There you go, recruit.
That's right. Thank you again, Gay, and thank you to Becker's to help provide this platform. It's been a wonderful conversation.
Great, thank you so much.
That is all the time we have for today. I want to thank Lisbeth and Gay for an excellent presentation, and AvaSure for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console. And don't forget to fill out the post-webinar survey. Thank you for joining us, and we hope you have a wonderful day.